Thank you all for joining us this evening, and I'm going to go ahead and ask people if you are attending via a cell phone number where your name is not identified. If you could please put your name in the chat. It looks like we may have everybody identified now. So look on the participants list and make sure that we can see who you are. Thanks for joining us. And Sarah, if you'll go ahead and go to the next slide. Just a review of our agenda again, we're going to mainly have some updates from OHCA. We'll provide some updates and then talk about what's coming next and any other business. So probably a shorter agenda this evening. Next slide. First, I'm going to turn it over to Joyce Marshall with the State Department of Health, and she will provide a few updates.
Thank you, Barbara. We didn't take up much time because I know we're all very excited to hear about the Oklahoma Healthcare Authority and the Medicaid updates and events that are upcoming. But did want to let you know that we will have the 2022 Maternal Health, Morbidity, and Mortality Annual Report. Will be out very soon. We'll make sure it goes out to the listservs for OPQIC and the Oklahoma Maternal Health Task Force, along with several others. There's good information in there about the health of our maternal, including the morbidity and mortality, along with recommendations from our Maternal Mortality Review Committee, who has reviewed the deaths and the conditions of those deaths and made recommendations for moving forward and having better outcomes, because we are making some improvements and we want to continue those improvements and continue to decrease those rates. So I just wanted to let you know that's upcoming. That will be coming out soon, along with some other kind of exciting items that we'll be able to discuss at our next meeting in January. So stay tuned for more events and more actions in that regard. Thank you, everyone.
Thanks, Joyce. Does anyone else have any updates they'd like to share this evening? Teresa, I don't know if you're able to come off mute and just provide an update about the family care plans. Sorry to put you on the spot, I should say.
Sorry. Actually, I'm at the office right now fixing up our PowerPoint. So we are starting our pilot kickoff tomorrow with the Tulsa County DHS and several of the hospitals there and our treatment providers. We will actually be doing our pilot and study for implementing the family care plan, and we're super excited. November 1st is our actual start date, but we're doing a deeper dive in training tomorrow, and then our family plan coordinators will have a meeting later this month as well to really dive into how we can help people implement this within the medical, child welfare, and treatment community. And then we also were selected to be a part of a new policy academy. And it's similar to the work that we have been doing currently, but it also involves tribes. And so we have a training tomorrow for that as well. And so we're really excited about that.
And the family care plan training is Thursday, correct?
Yeah, I'm sorry, Thursday.
Okay, I just wanted to make sure if anybody's
I'm sorry. We're going up tomorrow to get everything set up, but yes, it is. It is.
Okay. If anybody's on the meeting today and in the Tulsa area, and then we are able to attend the family care plan meeting, you can email me or put your name in the chat and I'll send you information if you didn't receive the email, but you should have received the registration email today. Looks like Mindy is sharing some things in chat. Mindy, did you want to go ahead and update coming off mute?
Sure. Sorry, I'm not in a place where I can do my video, but yeah, I just wanted to announce that Take Control Initiative has received a pilot grant to start offering our just in case kits to Oklahoma County residents as well as Tulsa County. So please help us share this good news, and I will be dropping off kits starting Thursday, so Friday people can pick them up at a variety of locations in Oklahoma City area, as well as our continuing locations in Tulsa. So let me know if you have any questions. I put a screenshot of what the kits look like if you're interested.
Great, thanks so much, Mindy. I'll follow up with you so we can send out information so everyone can make sure they have that information. So appreciate that, and the resource, that's very exciting. So we thank you. Anybody else have any updates?
I have an update, Barbara. This is Heidi Russell with Coalition of Oklahoma Breastfeeding Advocates.
Hi, Heidi.
Hello. I wanted to invite everyone to COBA's fall meeting and Maternal Health Matters panel discussion on October 25th. One of our panelists is Lori Applecamp, who I see who's on the call today. I will put the registration information in the chat. We also have a representative from the Southern Plains Tribal Health Board, in addition to the Tulsa Birth Equity Initiative. And then Dr. Kate Arnold will also be one of our panelists with ACOG.
Thanks, Heidi. Yeah, if you'll send me that information, I can share that as well.
Thank you.
Barbara, I just have one more item. If I have just a minute that I wanted to state, because I don't think it's been stated to this particular group. But I did want to be sure and announce that the infant mortality rate is at a historical low for 2019 to 2021. So it's at 6.6 thousand live births. And like I said, that is a historical low. And we still have lots of work to do. The work isn't done, but I do want us to celebrate along the way when we accomplish events. And it's taken all of us working together for several years to do that. Since kind of beginning and pulling people together, and the precursor collaborative to this, and also working in conjunction with this with Preparing for a Lifetime and the Commissioner's Action Team to Reduce Infant Mortality. Since that time period in 2007, 2009, it has decreased by nearly 20%. And like I said, for a 3-year sustained rate, we're at a historical low. So I do want to pass that news on and give us something to celebrate there.
Wow, that's great. So very exciting, that just to show that the work that we do does make a difference. So thank you all for joining and for sharing those updates, and I will pass them along as we after the email and after the meeting in a follow-up email. Sorry. Thanks so much. If you'll go to the next slide, Sarah. And I am going to turn it over to Casey McCarty from the Oklahoma Healthcare Authority, who will be providing us with some updates. And we appreciate your being here, Casey.
Thank you, Barbara, and I want to say thank you to this collaboration for giving me the platform to present our annual post-award form. If we continue to the next slide. Am I driving or?
No,
I'm
we're
sorry.
driving. We have
Okay. Okay,
the slides.
So our annual post-award form provides an update on our 1115 Sooner Care Choice demonstration waiver for the calendar year of 2021. And most of the things I'm going over are included in our last report. If you want to go to the next slide. So the presentation includes the 2021 status on the following topics. We're going to talk about our amendments in 2021, the challenges, achievements, and monitoring activities of waiver programs, including the Patient-Centered Medical Home, Insure Oklahoma, the Health Access Networks, and Health Management Program. And then we'll talk about what's in store for us in the future and give a chance for comment. So next we'll go to waiver amendments. Let me keep going. Thank you. During 2021, 5 waiver amendments were submitted to CMS. 2 of the requests submitted included the Insure Oklahoma individual plan phase out and the FPL increase for the IO employer sponsored insurance program, which were both approved, but not until early 2022. 2 new requests were submitted. One was to implement the Sooner Select managed care model, and the other one was to enroll certain Medicaid members, including expansion adults and former foster care youth under the demonstration. Both amendments are currently on hold from CMS review. The agency withdrew one amendment, which was to increase the rate for ITU care coordination payments, and that was withdrawn in July. Next are challenges and achievements. So the demonstration's most recent annual report talks about the third-party managed care delivery system transition as a key challenge during 2021. We actively worked with CMS throughout the year. We had a really tight deadline with an October 1, 2021 effective date, which was then halted on June 1st due to the Supreme Court opinion invalidating our authority to move forward. Another key challenge continued to be the public health emergency, but in 2020 we were afforded authority under a section 1135 waiver, which allowed us to waive or provide certain flexibilities to support members and providers. So that carried through and still does to this day. Another key challenge was our Medicaid expansion. The new state constitution article that was added July 1st of 2021 and had us mandated to expand by July 1st of the next year. Next, I'm sorry. The activities under the Medicaid expansion included phasing out our Insure Oklahoma and sunsetting the individual program of Insure Oklahoma. We moved members from employer-sponsored insurance who were eligible for expansion to the expansion group, and then we had to phase out the individual plan pursuant to a CMS approved phase out plan, which included a lot of steps and communication towards members. All those activities were completed though by June 30th, and we were able to sunset the program. It does still remain in our waiver though, because during the PHE, no benefits are terminated, so that for eligibility, so that program remains. Some key achievements. So Medicaid expansion was noted as a challenge. However, it's also a big achievement for our agency. We submitted a SPA and received approval from CMS to enroll adults into Sooner Care effective July 1, 2021. And enrollment opened in June 1st. And the media campaign began around July to reach other adults who may qualify. In September, so 3 months later, we received CMS approval to then enroll eligible expansion adults who could be within this Sooner Care Choice demonstration into the demonstration. So between July and December, our enrollment increased about 25%. And then as of the end of the year, December of 2021, 230,000 new expansion adult members were within the program. We also received the Governor's Award during the 3rd Annual Governor Leadership Summit. It was just to recognize our work for Medicaid expansion and working towards the new delivery system to improve health outcomes. So that takes us to our enrollment. Overall, in the Sooner Care Choice program, the enrollment has remained pretty consistent up until March of 2020, the beginning of the PHE. Since members are afforded continuous eligibility, no one is removed from coverage unless they request to be, or they move out of state. Through June of 2021, we experienced a 42% increase due to the adult population coming on and a 19% increase in children 0 to 18 years old. This slide also shows a decrease between June to July, where expansion members moved from intra-Oklahoma to expansion adult population under Title 19. And then it shows the jump in enrollment from when we transitioned members back to Sooner Care Choice from Title 19 in September. Next, talk about access, quality, and outcomes for the health management program. The state's independent evaluator, PHPG, issued an independent evaluation on this program for 2019 and 2020. The report included participant satisfaction, quality of care, and cost evaluations utilizing a HEDIS measures. And out of 19 measures that they used, there was only one measure that the comparison group exceeded this population in. And then on an aggregate basis, the health coaching portion of this program achieved a cumulative savings of nearly 26 million and a net savings of 10.4 million. So we consider that an achievement. Next is our, this slide has an error, but these graphs are exactly the same. So it's just whichever one you prefer to look at. So we're talking about our OU Sooner HON ER visits, and it's per 1,000 members from 2010 to 2021. That's the title that is blocked by the other graph. But essentially, we're just looking at a decrease in the emergency department utilization throughout the last decade. So in 2021, 79% of OU HAN members had 0 ER visits. So we're glad to see that continue to decrease. The Central Community HAN completed, which is not shown on this slide, completed over 600 contact attempts to 49 members who had ER visits. And they had a follow-up. It was reported that between the ER visit and the follow-up visit with their provider, it was about 13 days, which was 4 days less than 2020. And then the OSU HAN reported the quarterly average number of ER visits remained steady among their members that they engage in care management. Next, talk about program monitoring. So each section 1115 Medicaid demonstration waiver must be budget neutral. Which just means that the programs that operate under the demonstration cannot cost the federal government more than what would have cost the government without the waiver. So our budget neutrality figures remain similar to previous years. There's been an increase in overall Sooner Care and Insure Oklahoma enrollment numbers due to the PHE. However, we remain within the budget neutrality that is allowed. So the workbooks can be found on the agency's website, which is provided a little bit later. Next is our evaluation design. And this is another slide that has a rogue checkbox up at the top, but it should be under HMP quality of care, where there's the gap right there. So PHPG continued their evaluation activities during 2021 in accordance with our approved design, and they addressed the following waivers: Insure Oklahoma, retroactive eligibility, the HON, and the HMP. So on this slide, we're looking at each component that they evaluate for each waiver. The 2021 annual report includes a summary of the activities throughout 2021. However, looking ahead, at the end of this year, we will submit the final interim evaluation design. So next, as I just said, PHPG's findings for 2019 to 2021 will be presented to CMS in December of this year, and a copy of that will be with our renewal request. The current demonstration is set to expire at the end of calendar year 2023. So per regulation, we will be submitting a request to renew our demonstration as is by the end of this year. I should mention that we will have a couple of public hearings on that, and you can register once the public notice has been posted and the links are made available, which should be on November 1st of this year on our website. Sooner Select 2.0. So Senate Bill 1337 tasked the agency with reforming our current demonstration service delivery model to improve health outcomes and move toward value-based payments. And we are expected to launch this new delivery system in October of 2023. The dental RFP for Sooner Select was released September 1st of 2022. And it closes October 31st. And we are shooting to get the Sooner Select and Children's Specialty RFP posted hopefully by this Monday. And our website includes ongoing updates for that initiative. Next. So this slide gives you the ways that you can offer feedback or comments. You can submit to our email address there, or on our policy blog, there's a place to insert comments. Or I'm happy to take any questions or feedback from this group now.
Thanks, Casey. Does anybody have any questions?
Hi, this is Mindy from Take Control. I was just curious, so is Sooner Select 2.0 going to be what Sooner Care is now? Is that the new name, or it's another program?
It's a different program. Yeah, it's in addition to what we're doing today. It'll just serve some of the populations that we're already serving today. Okay. Sooner Care will still remain though.
Sooner Care will remain, but Sooner Plan is no longer, right?
Sooner Plan, so that's a Title 19 program, and it's kind of like the Insure Oklahoma individual plan program, where we moved those that were eligible for expansion to be an expansion adult. And then once the PHE ends, if there's anyone that is within the sooner plan, then they would be termed from that program, because that program will go away, but most of the individuals within that program move to expansion, so they get more full benefits.
Okay, thank you.
Becky, I see your hand raised.
Yeah, thanks, Barbara. Thanks, Casey. Yeah, a couple of questions, because I know Trevor had been kind of keeping us posted on some things that were of key interest to this group in particular. One was the reimbursement for doula care, so maybe an update on that. And then I know the new benefit for donor milk coverage for babies with a medical need in the home setting is supposed to take effect November 1st. So are those still on track? Any updates on those two?
So doula services, actually my fearless leader, Sandra Puebla, will discuss that next. So I'll leave that to her. I don't know that she was going to touch on donor milk though. So those rules are scheduled to take effect, the policy, in November 1. I think we're just still waiting on final governor approval, but I'd have to check on that. So I can get back to you though with a more concrete update.
Yeah, that would be great. Thanks.
Thanks, Becky. Yeah, we have more information coming on Medicaid next. Does anyone have any further questions for Casey? And you'll be able to ask questions after Sandra's presentation as well. Okay, well, I'm going to turn it over then to Sandra Puebla, who is the Deputy Medicaid Director for Oklahoma. And she is going to provide some other updates that are will be very relevant to this group. So I'll let you take it away, Sandra.
Good afternoon, evening, maybe. Thank you for having me here today. As you stated, I will be presenting on a couple of initiatives that we are working on that expand access to those who are pregnant or postpartum. So I've sent over a slide deck and we can begin that. So for the doula services, we began by being requested to explore whether Medicaid would cover doula services. And in the past, it was difficult to cover this particular services due to the provider type and the authority by which we could request it. However, in the past 5 to 6 years, there are several states who have submitted and received authority from CMS to have doula services. So we began our process by having stakeholder engagement, which began in March of 2022. The members within that work group were practicing doulas and community members that were interested in maternal and infant health outcomes. And the stakeholders were not there just to provide input as to how doula services work within the private sector or out of insurance sector, but they also weighed in on the program design and reimbursement. We really saw them as subject matter experts to help us design the Oklahoma specific plan. Next slide. So our proposed, I think we went too many slides. If you can go back one more. Our proposed implementation date says May 2023 or after. We are intending to have it be within May 2023 so that it can be part of the state fiscal year's budget. The after is because there are several things that can occur between now and implementation. You know, the holidays are upcoming. We have to take it through several meetings, and we're hoping, and that those have not been established for the new year. So This is the best date that we have today based on assumptions of next year's dates for MAC and our board. So I didn't want to say May 2023 and be held to that stake and then not have it be that day. So I put or after, but we are intending to do it prior to July 1st, so it can be part of this year's SFY budget. So the way that we did the coverage, or that we are proposing to provide coverage for this benefit, is to include 8 visits that can be prenatal and postpartum visits, depending on the member's need. Our stakeholder members noted that that is the usual amount of visits within that time period, but they wanted to ensure that it could be up to the member and that doula working together on what visits were prenatal or postpartum. So we just said 8 total for both of those stages in pregnancy and post pregnancy. And there will be 1 visit for labor and delivery. The visits will have to be 60 minutes minimum in length, other than the labor and delivery visit, because that could be either shorter or longer depending on that birth. They must be face-to-face, but we are intending face-to-face to mean telehealth for prenatal and postpartum visits. However, the labor and delivery visit has to be in person. Next. Because of the way that we have to receive authority for this benefit, it's under the preventive services benefit, and that particular federal authority the service has to be recommended by a physician or other licensed practitioner of the healing arts within their scope of practice under state law. For us, those are obstetricians, certified nurse midwives, and primary care providers, which can be physicians, PAs, or certified nurse practitioners. Next slide. We will create a form or template that can be used to meet the documentation requirement for the referral from those physicians that were aforementioned. We wanted to make it as easy as possible for the physician to just send the referral and not have to worry about what other items or what all is going to be needed in order to refer that member. So we are creating a template so that it is easy to check off and submit the information. There will be no PA required to access the 8 prenatal and postpartum visits or the 1 delivery visit. So that to us was a win, because if the doula and the member need it and there is a physician referral, they are going to be able to do their service plan as they need to throughout that member's pregnancy and postpartum. In addition, there can be a PA submitted if they've reached that 8 prenatal postpartum visits, if there are extenuating medical circumstances that show a medical necessity need for additional visits. So there is the possibility to go above those 8 if needed. Next slide. We wanted to afford doulas the most ability to practice their services within their scope of practice. And so we wanted to make it as member friendly as possible. So our service location for these services will be the member's place of residence, the doula's office, a physician's office, the hospital, or in the community. Because we don't cover home births. The doula services are also not covered when there is a home birth for that 1 delivery, doula visit. Next slide. There are some exclusions from reimbursement, and we worked through this with those work group members to ensure that we weren't placing too many barriers. But travel time and mileage, no calls and no shows are usually just part of the business of doulas. Transportation provided to the member, infant, and or family by the doula will not be reimbursed to the doula, as we have Sooner Ride, which is available. Obviously, room and board won't be a reimbursed service. The phone calls, text messages, and emails were also noted to be part of the doula work. So those are not going to be included in reimbursement. Certifications and recertification expenses will be up to the doulas to, pay for. Administrative overhead will be part of the doula's responsibilities as well. Group services won't be available for reimbursement. Services that are not medically necessary, as Medicaid has to have medical necessity criteria to be met. Multiple births will be counted as one, and there's no additional reimbursement per twins or triplets. And there's no separate reimbursement for false labor. So payment for false labor is included within the labor and delivery fee. If the member calls the doula and believes that they are in labor, and then the doula goes to the hospital and is false labor, then that won't be reimbursable until there is a birth or a ending to the pregnancy. Next slide. So the doula provider requirements is that they have to be at minimum 18 years of age. They will have to be contracted with us. They will be required to obtain a provider ID number. They will use that taxonomy that's on the screen. There won't be an ACA screening fee required of these providers. There is going to be an assigned provider type, which is other service provider. And in the future, in the interim, actually, we will have to create a provider specialty that will be assigned to them in the system so that their claiming can be done as expeditiously as we do every other provider type. Next slide. So the type of doulas that we are wanting to contract with are birth, postpartum, full spectrum, and community-based doulas. Based on the conversations with our stakeholders who were doulas, these are the ones that tend to be the list of doulas available. And so we wanted to create a full spectrum ability for them to be able to be providers. Next slide. Based on their feedback too, we noted down a list of organizations that could certify doulas and that the OHCA would accept as certifying organizations. As you can see on the screen, there are approximately 18 or more of those organizations that can certify doulas. Once we receive their certification and it's one of these particular organizations, they would have met the requirement. Next screen. So today we are not set on the reimbursement amounts, but we do know that the reimbursement will be based on a percentage of the current physician schedule. There will be a flat rate for prenatal and postpartum visits. So those 8 visits will be all the same amount. So every time that there is a prenatal and postnatal visit, it will be 1 flat rate per visit up to 8, and additional PA would be required for anything above 8, and those will also be at the flat rate. For labor and delivery, our stakeholders noted that there is different levels of care that is provided to women depending on the level or on the type of delivery that the woman has. So we wanted to take that into consideration and do a tier of rates as based on that feedback on the difficulty or the amount of work that it takes to be there for a pregnant woman and having those different types of deliveries. So vaginal delivery, cesarean, vaginal delivery after a previous cesarean, and then a different rate for a cesarean delivery following a vaginal delivery attempt after a previous cesarean delivery. That's a mouthful, but I know many of you in this group are very knowledgeable about what that means. So next slide. And now we're moving into a different benefit. So I'll pause here for a second and see if there are any questions about the doula benefit that we are proposing. I know it was quite a bit of information. We are definitely excited. I am an MSW by trade. And so for me, doula assistants and their services are very pivotal. I had them whenever I had my child, and I know that especially whenever you are apart from your family or have limited networks within your community, that doula is a godsend. They are a support both mentally, physically, emotionally, and so I could not be prouder and happier that we are opening that service. So I'll take any questions if you have them, and if not, I can move on to the next.
Sandra, I have This is Barbara O'Brien. I have a question. Thank you so much. First, this is really exciting, and really the impetus for getting this work started was because of this group. And
Oh, yay.
we went to trailer, and yeah, we've been talking about it for a while, and then so we're very excited that this was undertaken and that you all have done such amazing work here. I do have one comment. I noticed, Sarah, can you go back one slide? So the bottom labor and delivery visit, it says rate for a cesarean delivery following a vaginal delivery attempt after a previous cesarean delivery.
Mm-hmm.
I think something that sometimes the longest time that doulas are present during the birth experience is when there is a failed vaginal delivery. So they're in labor, but they have an indication for a C-section. So it's kind of like the bottom one, except they didn't have the previous cesarean delivery. So they went through labor and then ended up having to have a C-section. So I don't know if that would qualify for a different rate, if it's just going to be the rate for the vaginal delivery, or if there is a different one for that one.
So I can
We
tell
have
you.
discussed, but I just was curious.
So I can tell you that the very last one, the rate for that one will be the highest rate. And I believe, so it's, a member had a previous cesarean, attempted a vaginal delivery, failed, and ended up having to have a C-section.
Right.
That will be the last one. And I believe that's the same one you're mentioning.
No, the one what I'm mentioning is the last part where it says a vaginal delivery attempt after a previous cesarean delivery. She might not have had a cesarean delivery, just went into labor or was induced or whatever, and went through labor and was there for the
Okay.
labor process, and
I
then
get that.
ended up requiring a cesarean. So it's like a cesarean after, we call it different things, a reason to have an indication for a cesarean section. So I don't know. We can talk further, but sometimes those are the longest ones. They may be even sometimes induced for a few days and then don't progress and end up having so it could be failure to progress or something like that they need to have a cesarean delivery. So just something I saw that sometimes those are the longest ones.
Okay. I will double check whether I believe I understand what you're saying. I will double check whether the rate at the bottom will be allowed for someone who had a failed vaginal delivery and ended up having to require a cesarean delivery, or
Yeah.
whether the rate for the cesarean delivery, which is the second option, is going to be the reimbursement. And I can provide that clarity.
Yeah, because a cesarean delivery is often they're just scheduled and they
Right.
go in and have a C-section, and there's not a whole lot of time that's spent. So I see Hannah suggested maybe a C-section after following the vaginal delivery attempt, something like that. So just taking off that
After previous cesarean.
delivery, because it would apply to both.
Yes, and I do believe that would make more sense. And I will provide that feedback to the work group that is working to make this model into a actual implemented benefit coverage.
Okay.
Because the other one would be the third rate. Yeah, so I will definitely double check to see if we intended to put after previous cesarean delivery, or to just leave it as a rate for cesarean delivery following a vaginal delivery attempt.
Yeah.
I'll get clarity on that.
Thank you. I appreciate it.
No problem. There is a question
KPG iPhone. I don't know who that is. Somebody has a question. Go ahead.
Hi, it's Karen Gold in Tulsa.
Hi, Karen.
So sorry, I was driving and watching this on my tiny little iPhone. What is the proposed amount of reimbursement for this service?
So we haven't determined an amount. It will be a percentage of the current physician schedule. We have proposed a few rates to our stakeholders who are, like I mentioned, doulas. And we have not yet met with them for the, for the next time post the proposal of the rates. That's why I didn't include them on here, not because I want to be secretive or anything like that, but because we are working with them. We wanted to ensure that they provided feedback on the amounts that we're proposing and on the percentage, so that if it's too low or too high, they can give us some perspective. We based it today, the ones that were proposed to them were based on a national landscape view of those programs and those Medicaid programs that do have a doula coverage and reimbursement model already in effect, and attempted to see what the national average was for Medicaid. And so we have proposed those, but I didn't include the actual amounts because we haven't met with our work group again to see what they thought of the rates that are being proposed. So they're not final yet. There is a question on the chat from Amy Hawley that says that she's also interested to know if there are any specifics concerning those that have complications that may require more than 8 indicated prenatal and postnatal visits. So that will be a collaboration between the member, the doula, and likely their OBGYN. So they have to work in concert. From the conversations we've had thus far, those who are high risk pregnancies are likely going to need those additional doula services just because of the nature of their pregnancy being high risk. And so we are working through what those medical necessity criteria could be, what our doulas that we're working with in that work group have seen are usual reasons for additional visits, and we will take those under consideration and make them part of the medical criteria as we move forward.
I see there's another question in the chat also, Sandra.
Yeah, I think I would like to know how the proposed rates compare to CNM's rates for prenatal care, delivery, and postpartum. I just joined, so you may have covered this. So yeah, we did cover it, but not in specific rates. I'm not sure who the phone is. It just shows up as iPhone and then various numbers thereafter. But what I noted was that we are going to base the reimbursement based on a percentage of the current physician schedule. What we've done so far was to look at take a national look at Medicaid programs across the United States that have a doula benefit, and assessed a median type of amount, and have created the rates, and have posted them to our work group, who is made up of doulas. But we haven't met with them again in regard to the rates being assessed as the rates for this. So once we get back into meeting with them and having their feedback, we'll have a more concrete amount. But today they're just draft rates based on national view of other Medicaid programs. And then we need them to consider whether those rates are sufficient or if they're lacking, and then try to attempt a more a rate that is closer to what they may experience either in private sector or in their private practice. Okay. So if there are no other questions, I can move on to the next section. So another another really great thing that we're working on now is that we are hoping, if you go back up one slide, we're seeking to increase the FPL for pregnant women. Currently, pregnant women's FPL is 138% of the federal poverty level. We're hoping to raise that to 205% of the federal poverty level, plus the applicable 5% MAGI disregards, essentially making that final FPL at 210%. This is a big change. We had to go down to the minimum FPL a few years back based on a gubernatorial directive. But we're hoping to increase that to our highest level for pregnant women who currently today are in soon-to-be Sooners. But as you guys know, soon-to-be Sooners have their own limitations. Those benefits end upon delivery. There's no postpartum period. So it is limiting. So we're doing this in Title 19, which would afford the postpartum period, the full benefits of Medicaid, to a higher FPL. So that is, I believe, a great access proposal. We hope to make this effective January 1 of 2023. Next slide, please. One of the things that goes hand in hand with that increase of FPL is also to extend the postpartum coverage time frame. We're hoping to make that effective 1/1/2023 so that it can align with the increase in FPL. We want to do this because we want to not only increase access to service, but improve postpartum outcomes for both mom and baby. And so in this effort, we are going to extend the current 60-day postpartum coverage to a 12 months continuous eligibility postpartum coverage period. The really cool thing about this is that if a Sooner Care mom has a baby, then she is afforded the 12-month continuous eligibility postpartum coverage period. And not only is it more days, more months, but the only way that postpartum member can lose eligibility is if they pass, move out of state, or request to be terminated of Sooner Care voluntarily. Usually when there's changes in circumstance in the family, whether there's income changes or additional household members, or they move or whatever, and they lose contact of updating their address and they don't do that in time lapses, they can be termed from Sooner Care. With this particular authority, that postpartum woman is only going to lose that postpartum eligibility coverage period if they pass, if they request to voluntarily terminate from the program, or move out of state. Other than that, she'll have a guaranteed 12 months. And it will be full scope Medicaid.
Thank you so much, Sandra. So yeah, a lot of comments in the chat about this exciting news, and again, a lot of this began with this group because this is something that we've been talking about for quite some time. So we sure appreciate the Healthcare Authority for being responsive and listening and actually, making these changes, because it will certainly hopefully improve our outcomes for our pregnant people and during the pregnancy and postpartum coverage period. So thank you so much. And I did see one question about what will the reimbursement look like during this postpartum period?
So the postpartum coverage will be the standard rates of Medicaid. So if the woman accesses services, whatever those services are in the fee schedule, that will be the reimbursement structure for them during the 12-month continuous eligibility period. There is no change in reimbursement.
And so currently, I'm just curious, there's the global payment.
Mm-hmm.
So how is that going to change? Because right now, that's supposed to include like one postpartum visit. So
Yes.
how will that change when there may be more postpartum visits, or will she just be covered via the regular sooner care?
Yeah, so we will still require that, usual 6-week postpartum appointment, because that's a standard of care. And that is a requirement for the global reimbursement. So that will not change. Mostly what this 12-month continuous eligibility postpartum coverage period is to allow the woman to have the full scope benefits of Medicaid. So post, no longer being under the care of an OB, having the ability to seek out mental health services, having the ability to seek out her own physician services for regular things that happen throughout the first year of a baby's life. And so this coverage period being extended is more to allow that postpartum woman to have the full scope of Medicaid, not necessarily to have any type of additional requirements on ROBs. The usual treatment of care and the usual global payment reimbursement requirements will exist. However, then if thereafter that woman needs to continue to see the OB, then those visits will be just like you would any regular Medicaid member that just comes to you presenting for an OB visit. Barbara, you're on mute.
Sorry. I see your hand up, Becky, but one more question. Just to clarify, you may have said this, will this expanded coverage of the federal policy level continue until the end of this year also? So
for the public health emergency?
The 205% coverage, is that going to continue through the first year also?
So yeah, so extending to 205% FPL, we're hoping to make that effective 1/1/2023, and then continuing that on as the regular FPL.
Okay.
Mm-hmm.
Thank you. Becky?
Yeah, no, thanks for all that, Sandra. Very, very exciting news. So I have a couple of questions related to this that brings in the lactation benefit that we've had since 2008. So my first question, I hope is a quick one, an easy one for you, that's been based on the postpartum coverage, which runs out at 60 days. So does that mean if that's extended to 12 months, that if they hadn't gone through all their lactation, their 6 visits, and they have, say a NICU grad who's been in the hospital for 2 or 3 months, and now she needs the lactation benefits, will that still apply after the 60 days?
I am fairly certain that that is the intent. I'm glad you bring this up, because it's really important so whenever we make a policy change, there are indirect impacts, right? And so
Right.
we need to make sure that our lactation policy, our lactation consultant policy either matches the intent of the 12-month continuous eligibility, or provide very clear guidance as to, yes, we're extending the 12-month continuous eligibility, but the lactation consultant benefit will continue to be the way it is. There's a certain amount of units that can be used within X amount of time, or in the inverse, making sure that if there are needed policy changes, that they go hand in hand. So thank you for bringing that up. I'll have to bring back clarification on that, because I haven't looked at our lactation consultant policy in a while, but I'm glad you brought it up so that we can keep in mind to review that.
And then my other question relates to that as well, and kind of ties back to the doula benefits. So the lactation consultant benefit has historically, and this was a CMS requirement when it was, finally reviewed by CMS way back, but that the IBCLC had to also be a licensed nurse or dietitian. So is there a possibility now to revisit that and remove that licensing requirement? Because a lot of the IBCLCs that are providing home visits, outpatient, care are not necessarily affiliated, or, are not necessarily a licensed nurse or working, a lot of those are working in the hospital. So I know that the volume of claims for that benefit has been much lower than expected, and that's because we've eliminated a lot of the IBCLCs that would actually, be wanting to, file for Medicaid coverage because they're not a licensed IBCLC. And I'm sure not can't answer that today, but maybe something that we can
So
take a look at.
So your request is to explore the current licensing requirements for lactation consultants and whether there needs to be a revision based on current practice that is accepted nationally.
Yes.
Okay.
Yes. Thank you.
No
Thank you,
problem.
Becky. Hannah, I see you have your hand raised too.
Yeah, excuse me. I was just going to ask a similar question to Becky, but on the doula side of things, if those 8 visits, let's say someone comes in at the very end of their pregnancy, only has a chance to have maybe like 1 postpartum visit, labor and delivery, and then wants to have the majority of their visits done postpartum, would that be eligible for that full year with the expansion?
Let me make sure I understood your question. So you're asking about the doula coverage and being that there's 8 visits, whether in the prenatal period or postpartum period, and you're asking whether if they choose to do postpartum doula services, will they be allowed to be covered during that 12-month continuous?
Yeah, exactly. Thank
They
you.
will.
Okay.
That's
Excellent.
one of the reasons why we wanted to also do the postpartum coverage extension is because as we were looking at the doula services, and our doula stakeholders were noting that they have patients or clients, they have clients that are not really needing a lot of doula services during their prenatal period, but heavily need it after. And so when we started exploring that and thinking, well, if there's a 60-day limit, there is a limit to what they can do postpartum. So then it just even made more sense to go ahead and submit for approval of the postpartum coverage extension so that those doula services could be continued during that 12-month extra time.
That's great news. Thanks so much, Sandra. And I see there's a question in the chat from James Craig. Are you able to read that, Sandra?
Yes, he said, do you know, does the extension impact reimbursement for screening of postpartum depression? I know that ACOG guidelines recommend at least 1 postpartum screening, but I have heard part of that guidance is based on the assumption that pediatrician may pick this up at the next provider since most women only have 1 postpartum visit allowed. With additional screenings in the 12 months be covered? It is my assumption that it is. So a couple of things. So if the 1 postpartum visit is highly recommended by ACOG and others in this field, and that is covered already. However, if, for example, if there is a provider, a primary care provider outside of that OB that provides that for that member, it is my understanding that it will be covered because they have full scope benefits in that 12-month thereafter. We are also attempting to do we are trying to open up expert screenings in primary care, and we're exploring the rate methodology for that, but that is another initiative that I didn't put in the slide because it's not finalized yet, but we have received approval to allow for expert screenings as well in primary care. So yes, James, I think that would be something that would be allowed in that 12-month postpartum because they are they can have full scope benefits.
Awesome, thanks.
Thanks, Sandra.
It's good to see you, James.
I do
You
want
too.
to point out too that the global fee, you mentioned the ACOG recommendation for the 1 6-week visit. They now actually recommend 2 visits postpartum, 1 within the first 3 weeks, and then another at 6 weeks, but also sometimes they may need more. Say that she had complications with hemorrhage and maybe even had to go into the ICU for a few days or something. So she might go into a visit and then require frequent visits, like at least every week. So just wondering, they say that first visit, and then you determine how often she needs to have other visits. So I don't know if that's something else you guys could look into.
Yes, I definitely will. It is great that Casey and I are both in this call, because she is our director of health policy. So she noted that lactation visits today in rules are limited to 60-day postpartum in rules, but the rules are going to be amended to make it 12 months. So the visits can essentially be provided within that 12-month, because we are extending that postpartum period. So that is one of the answers that were posed. And so we got the response. It is still going to be limited to no more than 6 sessions. That's not changing, but the period of time can be anywhere in that 12 months rather than those 60-day postpartum.
And somebody asked about when ACOG added that extra visit. It's been in place for a couple of years now, I think. I'd have to search and find out for sure, but recognizing that often there are problems before 60 days. So they do recommend at least 2 postpartum visits. Becky, I see your hand up.
Last question.
You're
Sorry.
fine.
And
Ask
I
away.
don't know. Yeah, I have to go here in a minute, but and Sandra, you might be planning to cover this, but just any updates on the donor milk benefit that's supposed to start November 1st.
And
So-
I can answer that. I got an answer while I was, or after I presented. So we're still waiting on governor approval. However, we have everything in place for when he does sign the emergency rule to go ahead and move forward. So I think the November 1st effective date is safe. His 45th day is actually Sunday, November 5th. So I would expect his signature
Around there.
Yeah.
Yeah. All right. Thank you.
On the maternal depression screening, our policy, state and federal, both align with the guidelines per the Bright Futures periodicity schedule. So if there is an additional screening covered or additional screening added to that schedule, then it should be within our policy to cover it.
Thank you. I see, and thanks. Please keep the questions coming. We enjoy these meetings when there's a lot of interaction. So I see Tracy Clark has her hand up.
Okay, sorry, I couldn't get off mute. Can you just revisit about so I get the coverage, postpartum coverage for up to a year, which is awesome. But did you say that postpartum visits are limited to 2?
No. So as far as the reimbursement for the delivery and birth, that is not changing. What is changing is the allowing for the benefits for the woman for her to seek out benefits, full scope Medicaid, rather than the 60-day postpartum period up to 12 months. So the way that the global and the delivery and all of those rates are being conducted, that is staying the same, other than whatever benefits can happen postpartum that were previously only afforded during those 60 days, kind of like the lactation consultant, and the way that we were starting to go down the route for doulas, which could only be provided in that 60-day postpartum period. That woman is now going to have 12 months of continuous eligibility in the postpartum period rather than 60 days.
Right. And I get that some, we used to do mostly one follow-up a visit at 6 weeks, or depending on what the type of delivery they had, it might have been sooner. But especially with the substance use disorder moms, we are bringing them back sooner, postpartum, like within a week or two, and then bringing them back again really as needed. And is that going to still be allowed?
Yes, I believe that is. We were not I was not informed that, practices as they occur today are changing in regard to reimbursement for the postpartum period for the OBs. So I would assume that, yes, that it would still be allowed.
Okay, thank you.
Mhm.
Are there any other questions for Sandra? I think
And
Sarah.
oh, sorry,
Go
hold
ahead,
again.
Karen.
You briefly mentioned soon-to-be Sooners.
Mhm.
Are you thinking then that they will be getting some postpartum services, and any thought to postpartum tubal sterilization for the soon-to-be Sooner patients?
So unfortunately, because of the federal regulation that allows for the postpartum coverage extension, that does not cover soon-to-be sooner pregnant women who are, so let me rewind a little. There's two types of soon-to-be sooner pregnant women today. There are those who are Oklahoma residents and have a legal status within the US. And then they are the other subset of women covered by the Soon-to-be Sooners program are undocumented individuals who are residents of the state. So for the women who have been placed under Soon-to-be Sooners who are residents of the state and with legal status in the US, they were placed in Soon-to-be Sooners because we had to decrease the FPL under Title 21 or under Title 19 to 138 to the minimum standard, because we didn't want to just get rid of everybody who wasn't able to be eligible in that way. We found a way through federal reg to allow those women, even though they are legally in the states and Oklahoma residents, to be able to fit under the soon-to-be sooner umbrella so they could continue to have benefits at least to delivery. Those women are now going to be back to Title 19 full scope and have the 12-month continuous eligibility. Unfortunately, that particular federal rate that allows for that is under Title 19, not under Title 21. So women that will still be serviced through soon-to-be Sooners who are undocumented immigrants will continue to have their services end at delivery.
Thanks for the questions. I think the next slide has Sandra's contact information, and we'll have the slides available on our website so you can access. But if you need to ask any more questions,
I am always available to answer any questions. I started my career in the perinatal, prenatal, baby world. Child health was, my first passion, and pregnant women, and providing services. So coming back to this particular setting has been a pleasure. Thank you for having me. If you have questions, you have my contact information. Don't be shy and don't think that you're imposing or anything. This is my job, and I want to hear concerns. I want to, if there are barriers to healthcare that we could possibly assist with in removing, or at least, making better, I'm open to that. I am thankful that you had me today. I appreciate the opportunity to come and share some good news, and let me know if you need anything.
thank you so much to Sandra and Casey. And we also, just want to say we're very excited about this news, and we want to give you all and Trailer and the entire agency who we've been working with, send our appreciation for being responsive to our requests for these things. So we appreciate it. So thank you so much.
Thank you guys for the work you do. We appreciate it. Talk soon.
Okay, thanks so much. Sarah, if you'll go to the next slide, I think we already did the questions and answers. Just wanted to provide some updates for OPQIC. Looking at the next slide, as just a reminder about Team Birth, which Oklahoma is the first state to implement statewide in all of our birthing hospitals. And we are able to do this through funding with a cooperative agreement between the State Department of Health and HRSA. And we are contracting with Ariadne Labs to help with this work. So the next slide will show the hospitals now that are currently implementing Team Birth. Our first hospital was St. Francis Hospital in Tulsa, and they were one of the 4 pilot hospitals to test the feasibility of Team Birth. Then actually it's the George Kaiser Family Foundation supported hospitals, but they are launched in March of 2021. Hillcrest Medical Center and OSU Medical Center in Tulsa. And then cohort 1 hospitals that are part of the OPQIC implementation launched in the spring, March and April of 2022. And then just a couple of weeks ago, we were at all of the other hospitals listed there for cohort 3 at their launches around the state. So we had quite a fun time driving all over the state of Oklahoma, and it was really fun to see everybody in person again. So if you'll go to the next slide, these are some of our pictures from our launches a couple of weeks ago. We have a big party, and most of the hospitals really spend a lot of time working on this to make it a fun time, and we are now having coaching calls. We have been having coaching calls, but that's part of what we do to support this work. We do monthly coaching calls with every hospital. We did prior to launch, and we're still doing after launch. So we're hearing just today about 2 of the hospitals that launched a couple weeks ago and how things are going well. So we're really excited to launch this statewide, implement it statewide, and we appreciate the support from the State Department of Health, Ariadne Labs, and HRSA. So the next slide, you'll see we are recruiting cohort 3 hospitals right now, and we had our first learning session this month. We will be launching at the next for the next cohort 3 hospitals excuse me, in March or April of 2023. So if you are interested, please send us an email, and we will provide you with information. And we will have a cohort 4 that will begin planning and preparation in the spring, with a planned launch in a year from now, in the fall of 2023. So that should bring us to, we currently have 44 hospitals in Oklahoma that provide obstetric services. So we are hoping to get every hospital to join in this initiative. Next slide. And also wanted to let you all know we've had some recent staffing changes. So we are having some changes here with Barbara Coop. You all know has been a long-time program manager. She began working with us in 2009. She retired at the end of August, and she has to take 60 days off, but then she will come back and work some with us part-time on a contract basis. And Elizabeth Oak, who many of you knew, our administrative assistant, has moved to Seattle. So we have hired Kimberly Melton. She's joined our team as the administrative financial coordinator, and she joined about a month ago. So you may be seeing emails now from Kimberly Melton. So just wanted to let you know about these changes that have happened over the last couple months for OPQIC. Next slide, Sarah. And just to close out my portion, just wanted to remind everybody that we are having our 8th annual summit. We've had to change, and the venue is kind of late in saying that we could have things in person. So we're really excited to have an in-person summit again coming up November the 18th. The time will be from 9 o'clock to 4 o'clock. The registration will begin at 8:30. There is no cost. And again, here it's at the Moore Norman Technology Center in South Penn campus in Oklahoma City. So the link to register is there, and Denise has also put in the chat. So we hope to see you all in person at our summit coming up here in a month. And next slide. Wanted to let you all know we have had Mary Goen on our agenda previously to talk about, Focus Forward and the long-acting reversible contraceptive trainings. They had to be suspended during COVID, but are back scheduled again. So you can see the dates here and the locations. The registration is on our calendar on our website also, or you can go to focusforwardok.org to register, or there's the QR code. So again, this is for providers who are using LARCs as part of their practice, and any clinical staff or administrative staff are also welcome to attend who would be assisting with the contraceptive care, and they provide a lot of information on billing and coding and how to purchase and things like that. So if you're interested, please visit the Focus Forward website, or we also have the links on our calendar. And next slide. Again, wanted to remind you all about the Maternal Mental Health Hotline that is now live. So think of 833 Help for Moms, and that is something that is available 24/7. So we want to encourage everyone to inform their patients and families and the community about the availability of this maternal mental health hotline. And next slide. Does anyone else have any questions or other business before we adjourn this evening? I don't see any questions or hear anyone. You may need to come off mute if you want to ask. If you're on a telephone, you can push *6 to unmute. Okay, well, then we will go ahead and adjourn. We'll send a follow-up email with some of the information that was presented today. Oops. Just so you know how to register for our quarterly meetings, you can register here, and you can be added to these quarterly Outlook invites. We don't want to send this out as a quarterly meeting, because then we get all of the emails about who's accepting and things like that. So go to our website to register for the quarterly meetings. Again, they're held every Tuesday quarterly. You can see the upcoming dates, and they're from 5 o'clock to 7 o'clock in the evening. We will be going over a lot in January. We tend to focus on the legislative agenda. So, because the legislative session will be starting the beginning of February. So please don't miss our meeting on January 17th. We hope to see you then. And I think, okay, just a reminder again about our upcoming event there for the summit, and then another reminder too about the Project Echo maternal health webinars that are on the first and third Thursdays at noon. And if you go to our website, you can register for those as well. Anything else? I think that's it. So thank you all. We hope to see all of you in person in November, and we sure appreciate your joining us this evening for lots of good information. And I know when all of these changes are actually finalized, we will certainly be sharing that information with you all. So again, thank you all for joining us this evening, and have a great rest of your Tuesday evening.